And before we go any further, I'd just like to take the opportunity to do an acknowledgement of country. So I'm currently at Burnet on the Woiwurrung lands, and I acknowledge all the elders, past, present, and anyone here, and acknowledge them that the lands were not ceded. I will hand over to Phil, who can introduce Suman.
Thanks, everyone. As Gail said, my name's Philip De Croo, and it's my pleasure to introduce Associate Professor Suman Majumdar, who has a very long CV, and I will make it very brief. He's the Chief Health Officer for COVID-19 and Health Emergencies at the Burnet Institute. He's an Associate Professor at the University of Melbourne. He has a clinical appointment at Epworth Hospital and has been involved in a number of years in building research capacity and improving TB programs within the region, most particularly within Papua New Guinea, where he is the lead investigator for a number of collaborative studies with the Western Province District. And he's also the reason why I'm working at the Burnet, because he brought me across many years ago. So I get the joy of handing over to my boss in a moment. But like normal, Suman has picked a very big challenge. He's going to be covering not just a couple of journal articles, but trying to put that in context about where are we with TB preventative treatment, and sort of contrasting the original study from Comstock from Alaska, which has underpinned guidelines for many years, with the contrasting results found in South Africa with Gavin Churchard's study and the maybe non-significant results and the sort of, is it conflicting or does it support? I think that's what Suman's going to lead us in an interesting discussion of. So you'll have a time for questions. So please feel free to put your questions in the chat, and we'll hope to get through as many of those as possible. Without further ado, over to you, Suman.
Thanks, Phil, for the very kind words, and back at you. You're one of the reasons I got into TV, and Gail, we've worked for a very long time together, including in the region. So really great pleasure to present at the first journal club for the year, and we've sent out links to 2 papers, and the topic here is around community-wide interventions for TB, with a focus on TB preventive therapy, or TPT. So Gail has acknowledged country. I'm here on Wurundjeri land on the north side of the Yarra River in Melbourne. So these are the 2 papers, and we're going to span over 50 years to go from Alaska to South Africa with cluster randomised trials. So I will use some abbreviations, and I will skip through some of the slides that have a lot of detail, but just to say that we're moving away from the binary infection, disease, or latent TB definition, and acknowledge that there is subclinical or asymptomatic TB as part of active TB disease, and that latent TB or TB infection is really defined by the immune response at this point. We don't have a test or a biomarker to really identify a viable MTB infection that does not cause disease in people. That's its own talk on it by itself, so I won't go into that. The background to these papers and the questions I want to have a discussion on today is that the WHO NTB strategy for TB elimination does recommend TPT to be delivered as a combination of approaches, including screening, diagnosis, and effective treatment. But it focuses on treating high-risk groups who have TB infection, and that's all geared with the aim of reducing TB transmission. What we know about TPT is that it does reduce progression from infection to active TB. Multiple studies in HIV and non-HIV with an effect size of 60 to 90% in preventing TB incidents. And that includes, a lot of those studies have been done in household contacts as well as people who have HIV and young children. Now, there's a separate question around what is the impact of this intervention at a population level, in particular outside the group that receive it. So I'll be talking about that specifically and calling that population level impact or community-wide impact. There is some modelling evidence, but no real trials that have shown a demonstrable impact of TPT given to at-risk groups such as people with HIV or household contacts, which is what current guidelines for WHO recommend, contributing to a reduction in population epidemiology, be it TB incidence, prevalence, or others. TPT provision, however, must be preceded by screening for active and exclude active TB, so it's not an isolated intervention. WHO recommends systematic screening for active TB in specific populations and settings, including in higher TB incidence settings, currently defined as greater than 0.5 TB incidence or case notification, 0.5% that is, or 500 per 100,000, but it does not recommend any population or community-wide testing or treatment for TB infection with TPT beyond those at-risk groups. So the research question is, does TPT, in addition to community-wide screening and treatment for TB, result in reduction in TB transmission? Transmission or population impact on TB epidemiology. So I'm defining that as that can be measured by changes in community TB incidence, and that can be measured by crude case notifications, as true incidence is very hard to measure. TB prevalence, which is often done through quite intensive cross-sectional TB prevalence surveys for disease, and or the prevalence of TB infection, which can be through cross-sectional surveys of TB infection, classically done in school age or young children to look at infection rates over time. The studies of interest here are randomised controlled trials, which are cluster randomised by design, either with a population-wide TPT intervention, or they measure the impact at the community level outside the study participants. So there are a number of randomised and cluster randomised trials that look at TPT given to contacts in clinics or people with HIV, but they measure TB incidence in those participants. What I'm going to be interested in today is there an effect in a geographically defined population beyond the people receiving TPT? Framing that again, does TPT, in addition to community-wide screening and treatment, reduce transmission? And those are the three. Oh, I just repeated that slide. Sorry, I did a better one than that text. So there you go. That's summing it up there again. Across those three potential markers of incidence, prevalence, and TB prevalence in children. I'll talk through this. You don't need to read all the text, but there are probably 6 good cluster RCTs. This is a literature review I did last year as part of my PhD thesis, and looked at that question. And they are historical as well as contemporary studies. And we'll talk about Comstock, but I just wanted to highlight there are also 2 other very old studies that are very interesting to read. Nebo in Tunisia and Horowitz in Greenland, where they actually did do block and village randomisation with incidence of TB as a measure over 6 years. The Greenland study was very interesting, with a TB ship going out to a remote population of 20,000 and did show a 30% reduction. There were then more contemporary studies. There's quite a number of studies in Brazil. This particular one by Cavalcante looks at a matched sort of cluster design in urban favelas in Rio, and they looked at contact screening versus standardized dots, they called it, in 22 clusters. And again, it interestingly showed a difference, which was quite surprising given the relatively small sample size. And there was a very large, impressive study by Ailes and colleagues called ZAMSTAR, which had quite a complex design for case finding, as well as a household intervention that included TPT. It did show a large reduction in TB prevalence, and they did baseline and end-line TB prevalence surveys, but that was not statistically significant. The 2 other studies are the ones I'm going to present today, so we'll get into those. So the first paper is by Comstock et al., and it's a community-wide control trial of IPT, or isoniazid preventive treatment, in Alaska, published in 1967. This paper is relatively short, and papers are written very differently and perhaps more eloquently, a bit more of a story back in that time. The intervention and the subsequent description is, though, captured in several other papers, so listed here. In particular, Mary Hanson's paper that describes the implementation, and then further follow-up progress reports and final reports of this Comstock study. So, sorry, I just can't see if there's any hands up or any questions, but it'd be better, I think, if I get through it and then we have discussion at the end.
Yeah, I'll point it out, Suman, if there's anyone who, there is.
Yep. So I'll go through a standard PICO format for these because they're cluster randomized trials, and then describe some of the results. So this was the setting was in Alaska in the 1960s to 70s, 30 remote villages, largely indigenous inhabitants, with a studied population of around 10,000 people. There was a high TB incidence of about 1% of that population. It was very extreme geographic isolation, with the weather and the snow precluding access for about half of the year. Access was difficult via plane or through rivers other parts of the year. The study population were adults and adolescents above the age of 14. The intervention was community-wide isoniazid for 12 months, and that was given to eligible household members. The unit of randomization was households, but I'll be clear, this was not through a household contact tracing intervention. It was just randomizing households in villages to receive isoniazid or placebo as a comparison. Tuberculin and skin testing or a test was not required to receive the IPT. There were quarterly nursing visits to those all households, actually, and financial incentives. It was a double-blinded study with placebo control, and as I mentioned, it was a household-level cluster randomized design. The primary outcome was community TB incidence measured by notifications. It included TB deaths as part of that. There was an active surveillance system in place. The secondary outcomes were TB infection prevalence in children, in particular 0 to 3, but they did 3 serial TST surveys and one quite before the period, in the baseline period. The time frame is quite interesting. So the paper that was circulated is around this cluster randomized trial that was over the first 4-year period. Then given the positive results, so sorry about the spoiler alert, I've already given you that, but then they expanded the TPT to all households, and that was then called a community-wide program. And then they continued follow-up through the surveillance system. So just expanding on that intervention timeline, and I've found some pictures. Sorry, the source image credit didn't come through, but it's from the Alaska State Library and the US Geological Survey, of just pictures of the main hospital in the town of Bethel and the region there. So there was pre-intervention surveillance and a TB infection survey in the 50s. In 1951, this was well before short course treatment for active TB. So the drugs of streptomycin and PAS only arrived in the 1950s. And the protocol then was isolation for around 10 months if you had active TB. The first program was a cluster randomized trial. So there was a baseline TB infection survey in children, so a subset of the population. But everybody in the study population was offered chest X-ray screening, and they tried to diagnose and treat active TB prior to the trial of TPT. As I mentioned, TPT was offered to all people in intervention households, regardless of TST result. There was no stratification that was reported for randomization. Then the second program was then community-wide TPT to all residents, and this was the second round of active case finding or chest X-ray screening at the end of the trial and prior as part of this next program over 2 years. Contact investigation and other interventions were not really detailed across the main paper and is mentioned a little bit in the second papers, but Comstock and his team were big proponents proponents of contact investigation and driving that policy. So it was a standard in the United States, but it's very likely to be limited in the study villages, just given the geographic isolation. As I said, the nurses only visited once every quarter to each village. However, the surveillance and notification system had been intact for a number of years and continued. So the follow-up papers were really looking at passive case detection and looking at the case registers. In the 1980s, there was short course chemotherapy, and then contact investigation was routine throughout the US. So these are the results, and the headline sort of 3 results I've got there in the blue, that there was a significant and marked decline in the primary outcome of incident TB measured by case notification, including TB deaths. That equates to about a 59% relative reduction. It was slightly higher at year 1 and then sustained out to year 6 after initiation of the study. And from a case rate, which is what they reported over that period, over 6 years, so that's on an annual to that, it's a 6-year case rate, it was around 4.7 in placebo versus 1.7 in the intervention group. The reduction, and this is the subsequent papers, was sustained at follow-up points in terms of case notification out to 19 years. And that 19-year report talked about this reduction of 2.8 to 1.3%. The reason the placebo group's a different rate to the initial study is that there was that crossover of the population, and they only included those who had placebo in the initial study and did not subsequently receive TPT, so it was a smaller group. And finally, with the TB infection in children, there was a marked reduction in particularly children under 3 years during that trial period, from 14% TB infection to less than 1%. So from the implementation perspective, of the 10,000 population, about 7,300 were participants, so an 85% coverage. And then there was an additional 6,500 in the further program, which expanded beyond the 30 villages that were randomised to further villages in the region. They reported that only 3% of the population actually declined. So the gap there was really around who they could reach. So that was due to quite significant community engagement that occurred prior to and during the study. The adherence was also quite high, about 70% in the randomised trial, and that dropped off during routine program implementation in the community-wide program to 50%. These 2 charts firstly show the case rate, as I mentioned, in placebo and isoniazid on this side, and then here are TB infection rates across 4 serial TB infection surveys over this time, well before the study in the 49 to 51 period, baseline 57 here, and then throughout the study period you can see the huge decline in all age groups. But the reason for the focus on the 0 to 3 is that their infection is likely not to be acquired. They're likely to be uninfected at birth and throughout that study period, so true reduction in transmission. From other results that are not this primary outcome, they nicely demonstrated a dose-response relationship between adherence to isoniazid in the percentage of medication taken. So there was a lot of pill counts in all study participants. And if you look at this table, the percentage column here in the placebo versus isoniazid, you can see that isoniazid outperforms placebo across all strata, but the effect is marked, with greater adherence as you'd expect. That indicates a true effect occurring. And again, with the TB infection, as I mentioned, the sharpest decline was during the RCT in that initial period. Sorry, I wrote the wrong year there, but it was from 14% in the start of the RCT to 1.7%. So there was a decline prior to the RCT. That's important to recognise, which is possibly introduction of active TB treatment or socioeconomic conditions. There was maybe our current modelers would not call it modelling, but Comstock reported just sort of did a counterfactual case, applied the rates of TB prevented in the RCT to the entire community and said this intervention could prevent 174 cases, and they achieved this with, which is a very, for those who implement, a very low number of staff for this study, 5 nurses and 2 clerks over 2.5 years, which seems quite astounding that they could collect this data and reach so many people. This last chart down here is the sustained reduction just from surveillance systems in Alaska in the dark line. You can see the very high TB incidence, and the orange bar just talking about the study period. So this is the sustained effect that often gets reported. So the strengths of the study is that there was household level randomization with double-blind placebo control, and there was strong internal validity to this design. There was high population coverage and adherence. The secondary outcomes of the TST surveys show biological plausibility. There was long-term follow-up, and the sustained benefit was reproduced with the subsequent programs. However, there are limitations, and one of this is the primary one is that this is a very unique setting. It's an isolated geographical setting with very limited population movement, where reinfection and re-exposure is unlikely to be a factor. People are essentially cut off from movement, and there's not people moving around. The authors noted limited socioeconomic development during the initial study period, but obviously in that follow-up period from the 50s onwards, there would be significant socioeconomic development and other determinants of TB infection and disease that would contribute. So certainly can't say that it's an isolated effect of TPT, but there certainly was an effect. From a validity point of view, just on that point I just made, that it's hard to attribute it just to TPT because there were treatment and there was 2 rounds of case finding. And from a trial design, there was only 30 clusters, which is relatively small for a cluster randomized design at this point, but that's what their resources allowed. And the authors did note that residual confounding may have been possible. They randomized, as I said, at the household level, it wasn't further stratified, and there could have been differences between villages. TB diagnosis was based on clinical and radiological criteria. There was very limited bacteriological confirmation as well as a major limitation. Move now to the second paper, which is by Gavin Churchard and colleagues, published in the New England Journal of Medicine in 2014. So just over 10 years ago, a trial of mass isoniazid preventive therapy for TB control. And again, they were really looking to reproduce a similar study to Comstock, but in a different setting. So this setting was in South African gold mines, and similarly, they had 30 clusters, but the unit of intervention here was what they called mine shafts, and as I've listed below, mine shafts are administrative units that included accommodation and work areas where miners came to work. The population for the study was around almost 80,000, and this population had a very high incidence of TB, almost 3% per year. There was also extremely high HIV prevalence of 27%. Notably, there was high worker mobility, people moving in and out from neighbouring countries and areas in and out of the mine shafts and the mining areas. The average size of the cluster was around 2,600 workers. There was stratification by baseline TB notification rate at that shaft level. The intervention was community-wide TB screening using symptom screen and X-ray, if positive, followed by 9 months of isoniazid, regardless of TST status. That was then repeated every 3 years. This was offered to all workers in the intervention cluster. The standard of care which occurred across both groups, was passive case finding and IBT only for people who have HIV and contacts as per guidelines at the time. Implementation was limited in practice, though, for that IPT, as well as antiretroviral treatment for HIV, which was rolling out during the study period. The primary outcome was cluster-level TB incidence, per 100-person years at 12 months after the intervention, and the secondary outcome was TB prevalence as a cross-sectional survey. This was a 5-year study from 2006 to 2011, and there was a primary analysis 12 months post-intervention. So there were 66% of the study population was screened of that 80,000 group. A high number were actually started on IPT, 87.2%. And there was a reduction in TB incidence during the period of provision of TPT. However, the primary outcome did not show a difference between intervention and control groups. So the p-value was non-significant for TB incidence across the two groups. The TB prevalence at the study end was not different between the two groups statistically. However, as I said, whilst during people receiving TPT, there was a difference between the two groups, which was immediately lost on cessation of the isoniazid. I'll come to that next point on this. So why did it not succeed? And I'm going to go a bit quicker through this study. There are 5 reasons I've put forward, including some from the authors. The main one is that there was a high migratory population. The miners, as you might initially think, that people are just living in mines, but they're not. They're actually quite mobile, and people were moving between the shafts and between home and work. So there was also not the same group of people, and there was new workers coming in and out of this setting. There was a very high force of TB infection. There was a paper published by Vinicki and colleagues that did some post-trial modelling, and they estimated the annual risk of TB infection at 20%, which is extremely high. And they said that even with 100% intervention coverage as per study design, there would have not been a significant effect on community-level TB incidence. The HIV co-infection rate was definitely a factor. It drives rapid progression and also precipitates risk for reinfection. The IPT was not linked as a package with ART during the study. The trial may have been underpowered. It was powered to detect quite a large reduction of 40% in incidence and 55% prevalence reduction. And the effect size was smaller than that, of course. There was also additional risk factors. So silicosis is a big risk factor, a known risk factor for TB and as a lung disease, and this was something that was a factor in these mines. So last few slides here, just comparing the two studies in a table. Population movement or openness was definitely a difference. The reinfection risk as a result was different between these two studies. HIV was a big difference. The coverage was higher in Comstock. The individual efficacy, if I can call it that, if you look at the effect on the individuals during treatment, but the community level impact did not occur with the South African study, however, it was sustained for Comstock. So final slide, 2 slides here, is that in summary, I think there is a proof of concept established that community-wide TPT, in addition to case finding and treatment, can reduce TB transmission measured by incidence and or prevalence of infection, but the context and the setting and the TB epidemic are everything. One thing that's often talked about in other studies is around durable effect of TPT, and just want to put forward that durability is not an effect of the drug or a person receiving drug, and then, because we all know if you give someone TPT that the risk of reinfection is there. The durability is a result of the setting and the risk of reinfection. So when would you consider community-wide TPT? It could be considered if it's combined with community-wide TB screening and treatment, for sure. It would need to be high coverage and uptake with high completion of TPT. It could be beneficial in low, I should also add low, but particularly moderate to high incidence settings where you're trying to reduce transmission, but it would not appear to work in hyperendemic settings such as the gold mine. And it could be considered in geographically isolated communities where there's limited movement or incursions with new active TB into the community. So the now answered questions are really, what are the epidemic thresholds for that suite of potential criteria where you could and would use TPT? There's obviously then an operational question around how difficult it is. Is it feasible to implement, get that coverage, and what would be the cost to do that? So in terms of just a shout out to colleagues, including our own team in PNG, where there are 2 studies that are looking at this very question that are close to completion and hopefully reporting soon. They're not randomized trials, they're implementation studies, SWEEP TB and the PEARL study in PNG and then Kiribati, where there are interventions to screen the community, treat active TB and apply TPT. In both of those studies, it's using TST and TB infection as a marker rather than to all community members, so not a mass treatment. Different regimens are being used. The definitive study to answer this question, I understand, has just been completed and is in analysis phase, which is the ACT5 study in Vietnam that applied a cluster randomized design to look at universal test and treat for TB infection using 3HP in that setting. So that's the end of my presentation. So I'm really happy to throw back to Gail and Philip to lead a discussion.
Thanks so much, Suman. It was lots of food for. We've had a couple of questions that have come up on the chat. For everyone here, if you do have a question and you'd like to raise your hand, it's often a nice way to interact. So please feel free to do so. It's quite a friendly community we've built. Before I get into the questions, Nashita has just posted a Microsoft Office form, so we'd love to get feedback from these sessions as well. So please click on that and provide us with that perhaps at the end of this. A question has come up from Helen about how we can separate, if there's any way, modeling or otherwise, Suman, where we can separate the effects of treatment from TPT. And I had a follow-on question from that was, is that actually necessary in any, whether it's active case finding or community-wide screening, do we actually need to do that? Or could we see it more from a strategic point of view, where if you're going to go into a community, you're going to have to do both, look for people who are have disease that's untreated and treat them? And is it therefore artificial to try to work out whether you need to separate who has disease and what the effect of treating them versus just treating the community at large?
Look, I'm happy to answer these questions. We're very happy for others to also give their thoughts, because I think most questions are not going to have a very clear answer in this space. So discussion's always welcome. But I think the overall question is, what is the additional benefit of providing TPT beyond screening and TB treatment? In terms of determining that effect, I guess it's either through a model or through the ACT5 design, which would potentially answer that question. But you'd need the right study population without contamination of effects. Again, I'm very happy for others to comment and give thoughts, because it is an interesting and complex area.
Great. Phil, do you want to take the next question? Or Helen's got her hand up, so maybe we could go to Helen.
Yeah, I was going to suggest going to Helen and then asking Katie to comment, because I think there's some interesting comments in the chat, and it'd be great to bring those discussions in on this point. So, Helen, over to you.
Thanks. Yeah, thanks, Suman. That was a really good presentation. I think this is a really key question about separating treatment, and I think Anna has put a really good comment in the chat that in the first study in Alaska, they were screening based on chest X-ray and diagnosing on X-ray. So they may well have diagnosed asymptomatic TB, which would have not been done in South African mines. So that's an interesting observation. So they may have treated much more TB than they would have in the mines. And that would be one way to perhaps try and get to the bottom of this question, is to sort of see how much TB was found during the screening part of the intervention and how much was treated. Otherwise, I don't really know how else you would distinguish these two effects because they happen at the same time. While I've got the floor, I've got one more sort of question, which is around, I've always wondered about at what stage of the epidemic you're at when you try and look at interventions and the effect of them. So in Alaska, as in probably other places, when they started to do this, it coincided with sort of improvements in social services and socioeconomic status, which we know has sort of impacts on TB transmission and, TB vulnerabilities. Certainly wasn't the case in the mining sector in South Africa for the second study where, ongoing poverty, none of those socioeconomic factors that drive TB would have changed over the course of that study. Thanks.
Thanks, Helen. Just a response on the first point of the TB screening. I think Katie made a comment that's right. There wasn't comprehensive community-wide screening because they said it was very difficult to screen everybody and get to every village. And it would have been X-ray, and there wasn't sort of ongoing. So again, the implementation is often not very completely described, I would say, with particularly concurrent policy or what occurred. And they didn't give a coverage from what I read on X-ray screening for active TB, nor whether on the follow-up quarterly visits were they, actively looking for TB when the nurse visited. That wouldn't have been with an X-ray, but did they then pick up groups, and were there differences around that? But yes, I think that certainly we know asymptomatic TB is a major driver through there. I don't know, Anna, you wanted to comment?
I also thought, sorry, my internet is a little bit unstable, so I'm sorry if it's not very good, but Anna, you've got your video on, so do you want to go ahead?
I think did Suman say did I want to comment? I'm not sure.
Yeah, it's an invitation to comment.
Yeah, no, I think it's thanks for comparing these two studies. It's really interesting to see, looking at the kind of, I guess, the designs and where does it work and not work. But I think finding out what those TB screening rates at baseline were, I think is kind of one of those key things, particularly if they're doing it community to community based, and therefore the kind of the incidence in the community that was randomized is also really important. There were particular things going on in each community that would have influenced the response to the intervention, which I'm not sure how much that's been taken in, how well those kind of communities were randomized in their overall epidemic. But that table 5 that you showed, Suman, looking at the treatment the doses taken, you can see even with 0 doses taken that there was a lower incidence in the intervention group, suggesting that potentially overarching lower levels of TB to begin with. So you're kind of masking out an effect potentially there as well. But I think, the really looking at how well you actually screen out TB before putting people on treatment with TPT is the kind of the crucial thing. The evidence that does exist shows that isoniazid-based treatments aren't effective for asymptomatic TB. But then, therefore, in the minds, they would have been giving people inadequate treatment potentially. If they only looked at symptom-based screening, whereas they would have screened out many more people with asymptomatic TB in the Comstock study. So I think kind of how you design that is really important, because if you're only giving TPT to people who actually respond to it, then you'll have a much greater effect than treating people with asymptomatic TB who won't have benefit from it.
I did read the Churchyard paper, though, as symptoms and X-ray for all, but again, they didn't report coverage rates.
It said symptoms and chest X-ray if positive in your table.
Yeah. Okay. Why did I write that?
Which would have been, I guess, the screening guidelines at the time, right?
Guidelines, yeah. I think it was less screening with X-ray, but again, the algorithm wasn't reported in the paper methods. I agree with you. It's important to have that really clear, and it's not clear in both papers.
But also the kind of migration is super critical, and yeah.
I'm wondering if I can bring Katie in, because a couple of interesting comments in the chat. And Katie, I'm just wondering, to put you on the spot a little bit, what do you think we've learned from these papers that we could apply to future trials? And maybe a question back to Suman. Do you think we need future trials, or do you think there's enough work on this already being done?
Thanks, Philip, for putting me on the spot. I guess as a way of just beginning with my thoughts, can everyone just put up their hand? Everyone who's listening, can you just put up your hand? Is anyone listening to me? Yeah. And now maybe pop up your hand again if you take 12 months of isoniazid without testing prior. Someone would? Yeah. I feel, and with the, I don't know these studies as well as you do, Suman, and this is such a fantastic presentation because I didn't realise there were those other papers about the studies and things, and look forward to looking at them. But with the 1967 paper, it's not clear to me how many of the group in the Alaskan trial were screened for TB before study commencement, and they gave the results they were stratifying it by groups, and a large proportion had an unknown TB status. And then there was a group that had untreated previous TB, and then I think there was a group with treated previous TB. And the only results that they gave in terms of the prior TB history in the 1967 paper was in the placebo group, and over 40% of them had previous TB in that group that they gave us the information for, which wasn't the whole placebo group. And over 50% of that group had never been treated for that TB. And so just from reading the 1967 paper, the thing that struck me was that why are they going into the community and providing 12 months of isoniazid for everybody over the age of, I thought it was over the age of 2 months, but perhaps it was over the age of 14, I'm not sure. And then they're only providing it to half of the community, and there's a placebo group and an isoniazid group, when they knew that a huge proportion of those people in that placebo group had previously untreated TB. And if you look at the results, the study results in terms of the case rate reductions during the trial, the biggest effect was seen in that group, unsurprisingly. And I just think it's a big thing to do to give 12 months of isoniazid to people without prior testing and without certainly prior testing for TB. And it's just not clear to me that happened widely. And I think that might be one of the key differences between the South African and the Alaskan trial, is that if that is true, if the Alaskan trial if TB screening wasn't done systematically for everybody and for all participants, I think it was in the South African trial. So I think that might be the key difference, one of the key differences for why there was a difference between those two studies. I'm just speculating. I mean, we can only speculate. And on the question of how do we discriminate the effect of TPT versus active case finding, I think we know what the potential effect of TPT is on prior acquired infection, because we've got studies in low incidence settings looking at TB reactivation rates over time and the efficacy of isoniazid. And one of the key things to remember to know from those studies is that the reactivation rate of following a single prior MTB exposure over time is really low. The reactivation rate is really low. And the other thing to remember, I think, in terms of these studies, is that the risk of TB infection and exposure in high incidence settings is really high. And I think combining those two things. And I think also, obviously, isoniazid provides an effect against TB reactivation. We know that, but it also will, therefore, in these studies where there's higher re-exposure risks, provide effect against TB exposure and re-exposure in these settings as well. And so I think in terms of looking at the differences between the two studies, that might be the key thing. But the effect of TPT on the reduction in risk in terms of the effect of prior exposure would be small, I think. I don't know, does any of that make sense? I'll stop speaking now.
I was just going to say maybe the only way to really know what the effect of TPT would be to have a trial where you go into a community, you screen everyone who has got potentially asymptomatic disease, and I don't exactly know how you would look for that. Well, I do, but anyone with the disease, and you only provide them with treatment, and you acknowledge that there are people at risk, and you don't give them TPT, and a matched community where you really just provide TPT as well as treat disease, and then you'd know exactly the effects. But those two groups would have to be really well matched to be able to discriminate the effect of TPT on its own. One of the questions I was going to ask Suman was, I think the big thing that stood out, and especially in your table that was really beautiful and contrasted the studies really well, was the geographical isolation of both places, really, but the fact that there was so much movement in one and very, very little movement geographically and otherwise, and because of the weather for the other. And I wondered whether this type of strategy of finding people with disease and then treating the community with TPT would ever be reasonable in 2026. And I guess Act 5 will tell us that. Possibly, but there's so much movement of people across the world these days, not even within communities. I'm just not sure whether it would be, even if it does have temporary reductions, whether from a cost effectiveness it's ever going to be feasible.
Yeah, I think the more you read this stuff, and Katie, I think you made some really valid points. And I think definitely in the low incidence settings, you can study this. And I think, my point is around the efficacy is not under question. It's around can TPT add population benefit? So far we know that TB screening can reduce incidence and prevalence of TB. Comstock study seems to claim in this setting that TPT. I think for me, the interpretation is that it does have an additional benefit, but the whole part is around the generalizability of that study to other settings, to your point, Gail. And, it's about, ideally there are some kind of epidemic and movement thresholds, or we know that there might be an effect. But again, we don't really understand transmission well enough in each setting to know where that may be. But you could apply it, Pacific Islands, for example, could be a reasonable setting. I think that's certainly one could think about. The second point, I think, is just around TPT and IPT, to Katie's point around 12 months of isoniazid. I guess one reason to think about this is that TPT regimens and TB prevention strategies are going to, like HIV, hopefully get shorter, more tolerable, and will have them, not even, hopefully under a month, and even shorter going forward. So when we do have potential strategies, you want to know how to apply them effectively.
I might just pick up, there's a question earlier in the chat for Suman. Just any comments from the studies or from other studies around development of resistance with the sort of widespread community use. And then after Suman comments on that, I think Katie's got a hand up again.
Yeah, there's a lot I've read, so I might have got some numbers and misquoted some things, so forgive me if I have. And I think one of them was pointed out, I got the age wrong. It was 2 months or 2 years for Comstock, not 14 for the eligible population. In terms of resistance, I don't think it was certainly not on the radar in 1967 as an issue, other than them knowing that if you gave streptomycin, you became resistant. But that wasn't reported, and there was no bacterial confirmation, therefore no resistance testing. But from subsequent studies, we do know that that isoniazid IPT, when you exclude active TB, does not generate resistance. The key lesson there is really around excluding active TB, particularly in young children and adolescents, that it's clinically and bacteriologically difficult. So that's the group where it needs to be more stringent. So the more contemporary studies, such as Pearl and Sweep, are using, AI X-ray and more rigorous clinical assessment to exclude active TB for that very reason.
Katie?
Oh, thanks. So I was just going to say, so in my video, it's not starting. I'm not sure why. Sorry. In Australia, we provide TPT to groups who are systematically to contacts of people who have got pulmonary TB, and we only provide it to those who are immunoreactive, and that's because this group has a relatively high risk of TB reactivation, and even that risk of reactivation is not absolutely high. It's relatively high, as in it's higher than it is in other populations who are immunoreactive with no known recent exposure. But it's not absolutely high. And a lot of the TB that we see in Victorian TB program, for example, is co-prevalent. So there was no opportunity to prevent the TB at all. But anyway, and so effectively these studies that sort of provide indiscriminate TPT are expanding the provision of TPT to people with lower risks of TB from the prior exposure than we would provide TPT to in Australia. And I think that's important to think about. And this is being done in a high TB incidence setting where there's lots of people with TB. By definition, it's a high TB incidence setting. And I just think I think it's possibly the wrong approach to expand, several months of antibiotic provision, notwithstanding that the provision of the treatment may improve in terms of length and things, expand the provision of several months of antibiotic provision to people who have a lower risk than people we would provide that treatment to in Australia, a low incidence setting. We're expanding that provision in a high incidence setting where, sure, there may be some sort of transient, as Anna said, transient benefit from having that antibiotic treatment to protect against the high risks of re-exposure in those settings. But those high risks of re-exposure in those settings are caused by the many people with TB in those settings. And wouldn't it make more sense to provide antibiotic treatment to people with TB in high incidence settings than people without TB in high incidence settings? Anyway,
I think that I'm not sure if I'm wrong, but it looked like there was 90% infection in the Alaskan community. So there was very high incident disease. At least that's what I read, or my takeaway was. So Katie, I think that it's just such a different setting to Victoria, where, we do, quantiferon testing, and we only effectively treat those. I think you could very well make an argument that someone living in a household who does not have a quantiferon test should also be treated. Just because they're not immunoreactive doesn't mean that they're not infected, as you know, and you would be a big proponent of this. The usefulness of a quantiferon is quite poor. So I feel like, I don't know, I think that the Comstock paper still has loads and loads of value in what it's told us, in the fact that, yes, they only screened 800 odd people with active disease, but even just treating those, as well as providing TPT, albeit in a very geographically isolated population, had, huge benefits to that community. That was what I took away from it, and contrasted it with the Tabella paper, where there was obviously, lots of movement in the population and a high incidence of HIV. So, anyway, I should allow other people to speak, and a few people had their cameras on, and there was someone who had their hand up just now. Was it Nicole? Her hand's gone down. That's okay. We have a couple more minutes for anyone who wants to make.
I might just make one comment. I'm just back from Kiribati, and and just seeing a little bit of the work from Pearl, and obviously the team they will speak and present on their work. But it just got me thinking around also just the complexity of getting through a population in terms of screening when we try and say, you need to find active disease. Even with all the new tools, in a lot of settings, it's not as simple and easy, and getting it done and done quickly is just really challenging. And so I wonder also the speed with which, where there's very high transmission, how quickly you're able to screen the community and diagnose all the actives and get them on treatment. And then also whether or not TPT adds anything to that is also another factor to be related, because of the high rates of ongoing transmission as well as migration.
I might say one comment is that I think we can all agree that the overarching aim is to reduce TB transmission, and particularly in these high incidence settings. And the question we're trying to answer is how best to do that, and to a second degree how to cost effectively do that when there's limited resources and workforce. And I think in the other part that I looked at as part of this review was the evolution of WHO policy, and there was a point when WHO did not recommend community-wide screening in the 60s or TPT at all in the 70s, and we had divergent policies in high income and low income, but it was based on resources, not based on the TB epidemic. So I think targeting your interventions to your epidemic is perhaps the primary question here, that there's not cookie cutter approaches. And the problem there is we don't know enough about transmission to know where it occurs, other than that it does occur in the general community, and we need wide intervention. So I think most I think would agree that we do need community-wide interventions, but what and how and when is the next step to answer.
Maybe can I just add to that? I guess as you were framing it, the approaches to reducing transmission, and I guess I was wondering if there's kind of a thought of saying, okay, that there's two things we have to do. There is reducing transmission, and there's obviously people getting sick, and perhaps active case finding is likely the best way to reduce transmission. And TPT is also a great way of preventing disease in those most at risk, which would likely be the kids recently infected from getting, terrible TB. And it's less likely to have an effect in adults unless they're kind of a primary infection, which is less likely in a high burden setting. So kind of thinking about like TPT probably won't do much to transmission, but we still need it because we have to treat people who are most risk of getting worse TB, and thinking about who should get TPT in that scenario, and what are we trying to measure the benefit of doing that, and it's likely that active case finding and TB treatment will have a much greater benefit on the transmission, but we can't, I guess, forget about TPT, but aligning that to having reduction in transmission over the short time frame of these studies is probably not going to have that benefit. But if you measure it over a long time frame, then you're going to have a cumulative effect being seen. But I think really if it's a 5-year study, it's going to be limited amount of recent transmission contributing to that, except for the ones who are in kids that rapidly progress.
Well, we're at nearly 2:00. Thank you, everyone. And especially big thanks to Suman for these excellent presentations and starting off the Regional TB Club meeting this year. I really appreciate it, and lots of discussion, which was excellent. We will have the Journal Club run every month for the remainder of the year, and we've got lots of speakers lined up. If anyone is interested in presenting an article or their topic of interest and an article around it, I'd really welcome that. We do have speakers lined up for the rest of the year, but there's always movement. So I've just posted, yes, the Microsoft Office form for your feedback, please. It's one way for us to improve this journal club. And the second thing is to mention is that our next session will be Dr. Alvin from the TBCRE, one of the postdoc fellows from Greg Fox's group, who will be presenting some work that he's done, and his PhD student from Cambodia, and it will be anchored to a paper that they have reviewed. I've yet to find out what that paper is, but it will be on the it will come around with the poster and the ads that we usually sent out approximately a month before. So if you want to put that in your calendar at the moment, that's the 17th of April at 1 p.m. AEST. Thank you, everyone. And I better let you get to your next 2 o'clock meeting. Take care.